Good morning, everyone. I would start off by thanking Dr. Asma for the kind words. So, very good morning, respected teachers, seniors, and my dear friends. I am very excited to be here to discuss about a very basic yet very important procedure in our day-to-day practice, that is intrauterine insemination. I would like to start by asking how many of you perform IUIs now regularly in your clinic? So I see a hand going up there. So I hope by the end of the talk, everyone amongst here will be motivated to perform your own IUIs, because I feel just as ultrasound is a part and parcel of every gynecologist practicing today, IUI is also a very important procedure that helps you address the needs of many subfertile couple that walk into your practice. So this is not a new procedure by any means. We all know that sperm was first identified almost in early 1700s when Anton von Leeuwenhoek first invented the microscope. First documented intrauterine, or rather artificial insemination, was done by Cohen in a couple where the husband was suffering from hypospadias. The husband was asked to collect the semen in a beaker and instill it into the wife, and miraculously the lady conceived. We have come a long way from that point with a great improvement in the ovarian stimulation protocols and sperm preparation techniques. So today we'll be discussing the recent advances and evidences behind each and every step of intrauterine insemination. So let us start from the very basic. When a couple walks into your clinic with complaints of subfertility, there are a number of questions in your mind as to when do you start evaluating this couple, what is the basic history that you need to take, and what are the things you need to keep in mind, and what are the different available treatments available. So when do you want to start evaluating a couple? We all know that subfertility or infertility is typically defined as inability to conceive after 12 months of regular unprotected intercourse. Almost 1 in every 4 couple in our urban India is suffering from subfertility. So if we look back, where did this definition actually come from? So it came from a very interesting German study where they followed around 100 couple over a period of more than 5 years, observing their natural reproductive potential without performing any interventions. So of the 100 couple, almost 80 became pregnant within 6 months of trying, and 20 didn't become pregnant. So these 20 couples were supposed to be having moderate subfertility. So over next 12 months, 10 out of this 20 women again conceived, and the 10 didn't conceive. So this 10 women are thought to have severe subfertility. And it took more than 48 months for 5 amongst this last 10 couple to achieve pregnancy. So if we observe carefully, after 6 months of trying, almost 1 in every 2 couples will have some form of fertility issues which needs to be addressed. Therefore, if there is any known risk factor of subfertility, such as elderly age of the couple, or any endometriosis, previous surgeries, single blocked tube, or anovulatory cycles, or marginal male parameters, then it is worthwhile evaluating the couple even after 6 months of trying. And what is the basic history that we take, and what are the basic tests? So we all know the history usually starts from the demographic history of both the partners, their age, height, weight, BMI, and then from the female partner we are going to elucidate a detailed menstrual history, medical history, obstetric history, surgical, sexual history, and any addictions present. Similarly, in the male partner, along with the all above history, we are also going to take their occupational history, any infections such as mumps, and any history of inguinal surgeries or trauma. And coming to investigations, there is a long list of investigations available, but if we look at the basic test that needs to be done, for the female partner, hormonal evaluation, a good transvaginal ultrasound, if possible a 3D scan, and a tubal evaluation. On the male partner, the main test that is imperative is the semen analysis, about which you will be learning in a lot more detail in the afternoon session. So what do you have to keep in mind while treating a couple with subfertility, and what are the various treatment options available? So when it comes to fertility treatments, it is almost like a simple mathematical algorithm. The problem could be with the female partner, male partner, almost in 30% of the times it is with both the partners. So in the female partner, the problem could be at the level of vagina, cervix, uterus, tubes, ovaries, or one or more of them. In male partner, the problem could be with the count, morphology, or motility. Suppose imagine the male parameters are normal and female parameters are also normal, as we call it as unexplained infertility. The primary treatment will be IUI. If male parameters are normal and there is bilateral tubal block, the treatment of choice is IVF. If male parameters are normal and there is a premature oocyte failure or any history of gonadectomy for malignancies or anything, the treatment option is oocyte donation. And if there is uterine problems such as Asherman syndrome, repeated implantation failures, or hysterectomy done for any malignancies, then the treatment option is surrogacy. Now, if the male parameters are poor, like reduced count, reduced morphology or motility, and female parameters are normal, and the treatment option is ICSI. Whereas if there is no sperm available but normal female reproductive system, we go for IUI with sperm donation. And no sperm, no eggs, but the uterus is normal, you go for embryo donation. So it is as simple as that. Now coming to basic steps of IUI, we all know the basic steps are patient selection, ovulation stimulation, monitoring the ovulation follicular growth, final oocyte maturation, sperm processing, the technique per se of IUI, and luteal phase support. So the objectives of today's talk are, by the end of the talk, you should know how to choose the right couple for IUI, how to stimulate the patient, how do you monitor the follicular growth, when to trigger, what to trigger, how to trigger, proper timing for performing IUI, right technique for performing intrauterine insemination, what are the complications that you foresee in this procedure, and proper luteal phase support, and of course the laboratory practices in the afternoon session. So I personally believe that the God is in detail. You need to be diligent with each and every step, right from choosing the patient till luteal support, if you want to achieve even that 20% of success. So let us start with choosing the right couple. There are a number of indications for IUI. Intrauterine insemination could be a homologous insemination with husband sperms or a donor insemination. A donor insemination is usually done in frank azoospermia or inheritable genetic disorders in the male partner. Even in severe OATS, that is oligoasthenoteratospermia, if the couple is not affordable for an ICSI, then a donor IUI could be the solution. In homologous insemination, the indications could be psychosexual dysfunction or due to infertility or subfertility per se. The main indications being unexplained infertility, mild to moderate male factor infertility, mild endometriosis, single tubal block, anovulatory infertility, or cervical factors. When you come to psychosexual factors, they are mainly vaginismus, retrograde ejaculations, or erectile dysfunction, hypospadias, even an HIV discordant couple. So of all these indications, which couple benefits most out of IUI and which couples don't carry a good prognosis? So when it comes to couples where the age of both husband and wife is less, duration of infertility is less, they have good ovarian reserve, the lady has good ovarian reserve, good endometrial thickness, and when you do it for an unexplained infertility or donor IUIs or ovulatory dysfunction, they usually carry good prognosis. Whereas when the age of the couple is on the higher side, prolonged period of infertility where the oocyte reserve is very less or the endometrium is very thin with a very poor sperm quality or severe endometriosis, multiple surgeries with dense adhesions, these couple usually don't carry that good prognosis. And what are the basic prerequisites that you require to perform an IUI? The cycles should be ovulatory. It could be either a natural ovulation or a stimulated ovulation. At least one tube needs to be open, and total motile sperm inseminated should be minimum 5 to 10 million. And it also carries some contraindications such as any acute pelvic infections, cervical stenosis, when there is bilateral tubal block, severe endometriosis, very poor antral follicular count, or when there is a history of more than 4 failed IUI cycles, there is no point subjecting them to a repeated IUI cycle. So with this background, let us see few examples and try to choose if you are able to decide whether IUI or IVF should be chosen. So this is a couple where the female is 38-year-old, the male partner is 40-year-old. They are married since 11 years. The lady has endometriosis and she was operated more than twice. Left tube is open, AMH is 1, antral count is 4, and total motile sperm count is 20 million. What do you think? Should we offer IUI or should we take them up for IVF? So the next couple, a 24-year-old lady, a 36-year-old male partner, married since 2 years or trying for pregnancy since 2 years. The lady has irregular cycles, both tubes are open, AMH is 6, antral count is 24, both ovaries combined, and total motile sperm count is 10 million. IUI. A 36-year-old lady, 28-year-old male, married since 2 years. The lady has regular cycles, both tubes open with good ovarian reserve, AMH of 3, AFC of 8, and total motile sperm count is 60 million. IUI. And finally, you have a 24-year-old lady, 28-year-old male partner, trying for pregnancy since 3 years. Both tubes are open, regular cycles, AMH is 4, AFC is 12, and total motile sperm count is 2 million. IVF. So it is as simple as that. So now we decided which couple to offer IUI. So the next step is choosing ovarian stimulation. So do you really require ovarian stimulation for all the cycles even if the lady is ovulating naturally? The answer is yes. So this is a big study conducted over a period of 1 year in all the IVF centers in country France, and they came out with the suggestion that ovarian stimulation increases the number of follicles available for fertilization. So where the natural cycle has 1 oocyte, if you are able to increase the follicles to 2, the pregnancy rates increase by 3 to 4 fold. Also, using gonadotropins and stimulating the cycle corrects subtle underlying endocrine disturbances such as luteal unruptured follicle syndrome and all. Therefore, if you are offering IUI to the couple, it's worthwhile stimulating the ovaries as well. And when we come to the drugs available, the most commonly used drugs are clomiphene, letrozole, and gonadotropins. So clomiphene is the oldest and probably most commonly used drug. It is a non-steroidal estrogen receptor modulator. It is a triphenylene derivative of diethylstilbestrol. It is a racemic mixture of Zu and N-clomiphene. Zu-clomiphene is responsible for the anti-estrogenic actions and N-clomiphene is responsible for the estrogenic actions. So, unlike the natural estrogen, the binding of clomiphene to the estrogen receptors is quite prolonged. That leads to prolonged down regulation of the estrogen receptors, leading to a pseudo hypoestrogenic state in the body. This is detected by the pituitary hypothalamic axis, which leads to production of increased FSH that acts on the ovary, stimulating the follicles. But mind you, the negative feedback loop has been cut off by the pseudo hypoestrogenic state that leads to multifollicular development instead of the monofollicular development that usually happens. but the anti-estrogenic action is acting on entire body, leading to reduced cervical mucus formation and thinning of the endometrium. The next drug that is commonly used is letrozole. Letrozole is an aromatase inhibitor. Aromatase is an enzyme which converts androgens to estrogens in ovary, peripheral adipose tissue and in the brain. So when this aromatase enzyme has been blocked, there is no conversion of androgens to estrogens, so reduced peripheral circulating estrogens, that again stimulates the positive feedback loop of the hypothalamo-pituitary axis, leading to increased FSH. This increased FSH acts on the ovaries, causing follicular growth. But here the negative feedback loop is intact, so with letrozole you have monofollicular growth instead of multifollicular growth. Also, it doesn't have the anti-estrogenic action, so the cervical mucus and endometrial thickness is preserved. So various protocols available. This is quite simple. You start either clomiphene or letrozole from day 2 to day 6 or day 3 to day 7. Clomiphene is given in doses between 50 to 150 mg per day. Letrozole between 2.5 to 7.5 mg per day. You do sequential ultrasound monitorings for the follicular growth. Once the dominant follicle is reached, you trigger the ovulation and then do IUIs. So initially in the first cycle, if there is no dominant follicular growth, in the next cycle you will increase the dose of clomiphene by 50 mg and you will increase the dose of letrozole by 2.5 mg till the point where the ovulation is achieved, and that dose is continued at least for 3 cycles later if needed. So clomiphene or letrozole, which is better? Yeah, so there was a big study, a systemic review and a meta-analysis published in Fertility, Sterility very recently. It says that the total pregnancy rate per cycle, number of dominant follicles, multiple pregnancies, everything is no different between letrozole or CC, but the miscarriage rate, letrozole is better than CC, probably because letrozole doesn't have the anti-estrogenic action. Also, letrozole is found to be better than clomiphene in obese women in stimulating the follicular growth. Next, coming to gonadotropins. The injectable gonadotropins are definitely much more effective than the oral agents, but they are expensive. You need regular injections, and it comes with a higher risk of ovarian hyperstimulation syndrome and multiple gestation. In the market, there are various preparations available such as human menopausal gonadotropin, urinary FSH, both of which are derived from the urine of menopausal women, and recombinant FSH, which is produced by genetic engineering. Stimulation protocols with gonadotropins, they can be used either as assistive therapy or as substitution therapy when you are using them for IUI. Assistance therapy is when you add them up to clomiphene or letrozole, and substitution therapy is when you use only gonadotropins from day 2 till a dominant follicle is reached. So assistive therapies are also very good. They reduce the financial burden, reduce the number of injections required, while the success rates are almost comparable. So here you start letrozole or clomiphene from day 2 to day 6, and then from day 7 onwards you add on FSH, HMG, either 75 or 150 till the dominant follicle is reached. You do sequential ultrasound scans, and then when the dominant follicle is reached, trigger is given and IUI is done.